Okay, I'm stopping my video and audio also. If needed, just will be there and there in the background. Okay.
Just 1 second, sir. Can I share my slides so you can confirm my slides are visible or not once?
Yes, Nitin, please do it.
So we are live.
No problem, Nitin, just share it. Anyways, you have to share. So. Nitin?
Just 1 second, sir.
Huh.
I think it takes little time.
Okay, Nitin, slides are visible.
Okay, thank you, sir.
Go to the slide 1. Yeah. Okay, Nitin, keep it here only. Then it.
Okay. I think, sir, we can wait for next. Yeah, sorry, please.
Yes, sir. Sir, so, sir, we are already live. So we will start sharp at 5, sir. So there are 4 minutes to go.
Okay, perfect.
Ritu, just let us know, are we good to go?
Yeah, doctor, please start the session.
Okay. Nitin, over to you.
Yeah, thank you so much, sir. Good evening, everyone. My name is Nitin, and on behalf of Mankind family, I would like to welcome all of you for today's session, that is safe OPD management and offering COVID care to the patient. For this session, we do have Dr. Rahul Pandit and Dr. Prashant Agarwal with us. So before hand over this session to doctors, I would like to take only few minutes of yours just by introducing my company. So here in Mankind, sir, Mankind has been established in 1995 with a co-founder, Mr. R.C. Juneja. Sir, Mankind ranks 1 prescription-wise and rank 4 value-wise. So we do have strong presence across prescription as well as drug and veterinary medicine. Sir, our philosophy here is just serving life, which based on 3 parameters, that is quality, affordability, and availability only. Here in Mankind, sir, our strong presence in anti-infective, gastro, cardiovascular, anti-diabetic, nutraceutical, dermatological, and rest of the therapies, sir. So we do have our own R&D center, which is backed up by more than 400 scientists. So with this, just we would like to thank to all of you for the partnership in care. So we thank you for your continuous support, which is encouragement for us. Thank you so much, everyone. With this, I just would like to hand over the session to Dr. Prashant. Dr. Prashant, please.
Thank you, Nitin. And thank you, everyone, for joining us here. As we are already aware, India is reporting highest number of daily cases in the world. Almost 50% of new cases reported of the world COVID. OPD services have been suspended in several states while the patients are desperately looking for healthcare services. Providing outpatient service to a COVID-19 patient requires protocols should be followed and close monitoring of the patient. A telecommunication trial should be given before recommending in-person consultation to the patient. Hence, it becomes imperative to talk about the safe practices to run an OPD and managing an acute COVID patient in OPD. Today's webinar is on the safe management of OPDs and offering COVID care to the patients. And with us, we have our guest, Dr. Rahul Pandita, who is a Director Critical Care at Fortis Hospital and one of the handpicked physicians to be a part of the COVID task force of the government of Maharashtra. Now, let me introduce Dr. Rahul Pandita, Dr. Rahul Pandit sir to you. Dr. Rahul Pandit, Senior Intensive Care Consultant with over 2 decades of experience and the Director of Critical Care Medicine and ICU at Fortis Hospital, Mulund. Having a prestigious fellowship of Joint Faculty of Intensive Care Medicine Australia, Dr. Rahul Pandit plays the lead role in setting up ICU policies, protocols, and patient care algorithms. He has numerous publications and book chapters to his credit, along with the guest lectures in several national and international conferences. His areas of interest include critical care, echocardiography, trauma, neurotrauma, obstetrics emergencies in ICU, and proteomics and sepsis. As I told earlier also, he is an esteemed member of Maharashtra government's task force on COVID-19. And this task force plays a key role in establishing a patient management protocol for serious and critically ill patients. It also recommends the requirement of specialist doctors and healthcare support staff in the critical care hospitals, suitable drug protocol to maintain uniformity in treating critically ill patients, and recommends criteria and logistics requirements to transfer critical patients. So to address today's topic of discussion, we have Dr. Rahul Pandit sir. So now I welcome Dr. Rahul Pandit sir to take the time, sir. Welcome, sir.
Dr. Prashant, thank you very much for the kind introduction. I really appreciate the time and effort spent by you and your esteemed company to actually try and promote these safe practices, which are so important and well-mentally need to be followed across the country, in fact, across the globe, to try and keep the healthcare workers in a safe mode. Because right now, you could have money pouring in from all quarters. People may buy ventilators, beds, monitors, everything. But what you cannot produce and make is doctors and nurses overnight. And that's what we need. That's why it's very, very important that we need to protect ourselves so that we can actually efficiently give back to the community as much as they want it right now. it is very important that we keep ourselves safe so that we can be available for them. And this initiative is a very, very appreciable initiative from your side. Um, while it may involve a lot of common sense approach, there is some amount of scientific material which needs to be understood, especially in the treatment aspect. And remember, patient becomes sick, he seeks OPD consultation. They don't seek ICU consultation on day one. So OPD is the entry. Whether you seek OPD in the doctor's consulting room, or whether you present to the emergency department late in the night because the consulting rooms are closed, both of them actually have a patient who is going to walk through the door, and they don't know what is in store for them. So while for a person it may look like OPD consultation is a simple thing, you just look at the patient and then if they are treatable, you treat them or you just admit them. uh, they actually get the unknown. While the IPD patients, the IPD specialists, the intensive care people actually have some background of what is happening. It may not be a long background. It might be only 2 hours of history in the emergency department, but they still have the 2 hours spent by a doctor there trying to elicit a history and give some information. So they are better prepared. They are the second rung guardians of the patient, not the primary guardian. The primary guardian is always the person who sees them in the OPD or in the emergency department. So with that, I've got a small presentation which I would like to share with your esteemed doctors who have logged in, and then we can go through that in an elaborate way. Spend say 15, 20 minutes, 30 minutes talking about that, and then we will obviously have a good session of questions if at all you feel that's going to be important. All right. So if you're okay, I'll start my presentation.
Sure, sure, please. Sir.
Can you all see my slides?
Yes, sir, it is visible.
Yes. Thank you. So with that brief intro in mind, let me just start off, kick off the proceedings today. So as I said, that right now in this COVID pandemic era, where the cases have hit the roof, we are finding that almost 15 to 20% of healthcare workers in India currently are actually having problems with being contracted with COVID themselves, and this is a huge amount of workforce which is probably out of the active role which we are supposed to play, and they may be in various stages of their illness. Some of them may be in the active phase. Some of them may be still recuperating from the illness, because all know that it takes a good 2 to 4 weeks for you to at least get back to some form of a shape where you can sit back and do your work normally, and to be fit enough to be feeling as well as you felt before COVID hit you. It may take anywhere between 4 weeks to maybe a 6 months or even a year, and that's very, very important to understand. And that's why it's very important that we uh, you know target our day-to-day work which we are doing in a way that keeps us as safe as possible. So first thing, the OPD, outpatient department readiness. So it's important that you start looking at some form of a triage process where you have an access to a protocol, and whatever area of interest you may be working in, you still need to understand that you will require a tailor-made solution for your own place. No protocol will be actually tailor-made for you, which would be easily adoptable. So what you need to establish and reassure yourself is that you need to have a good screening process, you need to have a good protocol, and that would include on the place where you are sitting. So if you are working in a smaller district hospital or a rural healthcare center, it's going to be a little bit different. If you are sitting in your consulting room in your clinics, it's going to be a bit different. And as I said, if you're going to be in a hospital emergency unit, you'll have to tailor make it for that. Now, how do we approach that? I think the first and most important protocol in this is that whichever place you're going to see the patient should be well ventilated. We all know that closed and stuffy places actually worsen the transmission of this virus, and you're going to put yourself and your staff working with you into a considerable amount of risk. And this is despite you wearing a reasonable amount of protective gear yourself, which would definitely include an N95 mask and a face shield to the minimum, gloves to hand in your hands, and a protective gown, which will basically be above your scrub suit or your clothes, so that you at least have some form of basic protection. If you are in a profession where you need to look at patients' ear, nose, and throat, like an ENT surgeon or a physician who is actively going to look at the patients and going to auscultate them, then you probably need to think of a little bit more like a PPE kit, which would be a little bit of a barrier between you and a patient. But there are lots of various things which we can talk about. You need to have a screening process. So in your own little way, you need to understand that how are you going to screen these people? Are you going to screen them before they come to your clinic? That's the best way to do it. But if they do appear as a walk-in patient, what is the system that you can actually screen them properly? And each facility, wherever you are, will have to have that screening area set up. Even in small clinics in Mumbai or Delhi, where the doctors sit in a single room, you probably need to have some form of a basic screening before they enter your workplace or your building or your consulting room, and that needs to be very well established. Obviously, hospital emergency units, it's a bit easier. If you're in a hospital, it's a bit easier because you can actually earmark a separate area or a separate room for that to happen. It's also important that you need to have some basic facility to look after these patients in case you have a seriously ill patient coming to you, and you need to give them emergency care. It's extremely imperative that we need to be prepared for this eventuality, because as I said before in my introduction, we don't know what's going to walk through our door. We may have a perfectly fine patient walking in, or you may actually have a reasonably critical patient walking in, and when you put on a pulse oximeter in these difficult times, we all are measuring a pulse oximeter with our patient. You may find that the saturation is 70% or 80% or even below that, and this could happen in your screening room itself. You cannot by any ways just ask the patient to go away to some other facility. That's not what we are doctors as doctors we are trained to do. What we do is that we actually give them some basic emergency care and activate a referral center. So that process needs to be clearly defined in your mind. It needs to be written down. Phone numbers need to be kept ready. The operator or the receptionist or the assistant, whoever is there, should be aware of what is the procedure to be followed, so that even if you have not reached to your clinic yet or your OPD yet, and you're on your way there, or you've just left and some patient arrived before the OPD was actually shut down, they would still be able to implement this in a reasonable way, awaiting you to come and help them, obviously, and awaiting activated referral center to sort of come and pick up the patient, so on and so forth. There has to be a clear distinction for visitors now. We have to be very, very clear who you are going to allow inside your room. So patients who are positive, or visitors who have basically come into contact with a confirmed positive case, you need to have a policy that you probably won't be allowing visitors right now in the hospital or in your clinics currently. Um, Similarly, patients who have, they may not be having a confirmed COVID-19 case, but they may be having some form of an acute respiratory infection. In a pandemic time, remember, this is essentially to be taken up as a positive case only. And you put up your protocols in such a way that if you have a flu-like illness, ILI or influenza-like illness, what we call, you need to confirm that this is a COVID-19 unless proven otherwise. But most importantly, for those group of doctors and nurses who have uh, pediatric patients, or who may have adults who are dependent on other for emergency for their caregivers, you need to have a policy, because it would be difficult for you to actually refuse them from coming inside as visitors. There has to be a screening policy, and a good screening policy right now could involve checking their temperature. And I'll be coming up to those things in my next slides and talking about it in a little bit more elaborate way. So if you're going to run an OPD in this tiring times, you need to be sure that you're going to spend your time and energy concentrated in such a way that you will have a reasonable, stable thought process. If you've got too many things cluttered up your mind, you would probably make a mistake which you may not realize, and it inadvertently put yourself at risk. So one of the safest thing to do is that any elective work can wait if it can wait. That way you only concentrate on the work which is coming through the door. Because if you start thinking on planning about an elective procedure now and something comes up as an emergency, then you will be trying to do a very quick job, trying to finish that emergency so that you could attend to your elective job. And that's what happens all the time in doctor's mind. On a normal day, if you put yourself in what I'm trying to say and you put your thoughts in there, we all want, I mean, surgeon may want to go up and do a surgical procedure, or even a GP might want to actually go and do a simple procedure for which he may have called up a patient, and suddenly an emergency comes in. What happens is that you're neither able to concentrate and give a complete attention here or there. You try to do both of them, and we are trained to multitask at times, but not in these times. These times you need to be very, very clear that you're not going to do any elective work. If you can postpone it, postpone it. Clearly, you instruct your patients, do not routinely visit the OPD. Avoid it. If it cannot be avoided, try and do a teleconsultation. Teleconsultation is an easy way to do. There are several platforms, or the good old WhatsApp or a FaceTime call on a mobile is also reasonable enough. And there are several OPD platforms which allow you to do a teleconsultation with your patients on a very seamless way. Make sure that after you've done a teleconsultation and asserted yourself that, look, I've done to the best of my ability to try and rule out that this patient probably is not a high risk, and you feel that you're going to add on to the patient's treatment a little bit more, then you can call in for an inpatient consultation. All patients who have got COVID or COVID-like symptoms have to be attended separately. You have to give them a separate time slot, and you've got to space them out. You've got to space them out so that there is no cluttering. And patients who have got chronic diseases, minor elements, basically anything which can be weighted or can sort of wait, can utilize OPDs in primary or secondary care facilities if they can. And if you are working in some primary or secondary care facility as well, you could ask them to go and see you there. Some of the hospitals in the country have actually come out with quite ingenious solutions. And while you may feel that these are just ingenious solutions, for me, I think it's a very, very common sense approach. If you just put yourself and start thinking around you that how am I going to make myself safe as much as I can, you will come up with very, very reasonable and ingenious solutions. So Zydus Hospital, beg your pardon, I'm just going to go back. Zydus Hospital installed 4 high-end quarantine containers with negative air pressure outside the hospital so that they could have these patients come in, be screened there. And what do? Both the patient and the attendants have basically a screening procedure to go through, and they have to find and fill up a form well. If you are essentially declaring the information which makes you as a suspect, then during the initial screening, can you hear me? Hello?
Yes, sir. Your voice is audible, sir.
Sorry, I'm sorry. I thought that I had lost the connection for a second.
Yes, sir.
Because they
In
were
between, sir, for few seconds, yes, sir, there was some disturbance.
Yeah, because a message came to me, internet connections not stable. Anyway, I'm sorry about that. Let's continue. Um, you declare if you declare yourself with symptoms which may make you a suspect, then obviously the patient is sent into the emergency department where they have set up this process of screening these patients and examining them. However, if you are giving information which makes you a low suspect or a non-suspect, I would probably say a low suspect. In that case, your mask is provided and patient is allowed to go inside for OPD consultation. In OPD, the sitting arrangement is made in such a way that there is social distancing, and all the medical and non-medical staff who are in the arena who are going to interact with the patient have adequate safety gear. A similar sort of a process, but a little different in terms of what they have done, is set up by Care Group of Hospitals. So what they do is they encourage for video consultations, and they only ask the patient to come for OPD at the recommendation of the consultant. There is a very, very strict gatekeeping. They are very clear who needs to enter and when they need to enter. If they are not very clear, they would not essentially allow that to happen. And they have 3-level screening for every person who is entering the hospital. So you have a separate screening area for patients, separate for the attendants, and separate for the hospital staff, which is very important. You need to screen your hospital staff as well. If you're going to screen your patients and attendants, it's equally important to screen the hospital staff, because once you're outside the hospital, you probably are dropping your guard down, maybe not knowing about it, and you may be the one who would actually be bringing the infection to the hospital. While we are all as healthcare professionals now motivated to get vaccinated, and all of us probably are vaccinated. I certainly have got my 2 doses, and I've been more than a month beyond the second dose. But all of us need to endeavor that, as working people in the hospital, it's a primary duty to be vaccinated, so that we have a lesser and lesser risk for our patients and for ourselves. The registration desk, the doctor's consulting room, all of them have got a glass partition. It allows you a physical barrier from the fomites and from the droplets which might be formed, which might be coming onto you. And that actually has proven to be very effective way, because it also acts like a physical barrier between the patient and you. And most patients respect that, and they actually stay behind the barrier. Otherwise, when that physical barrier was not there, patients would actually come forward, lean towards your table and towards you, and start talking. And that and vice versa. Even while I am doing now, I'm trying to lean forward and talk to you. Do I know that I'm just talking onto a social media or a virtual platform? I still have that habit of sort of coming forward, and it sort of breaks that um, social distancing barrier which we like to do. Hence, that glass partition is very, very important. I said again, PPE kits, body care, gloves, and everything should be worn. Now, let's look at some of the practical aspects of how we actually look for these COVID patients, how we risk stratify them, and what are the current recommendations. So, if you look at the WHO recommendations, and we're going to go through the WHO recommendations and the ICMR recommendations, you have three types of care patients who sort of fit into the risk stratification. One who are asymptomatic or mild, and the second who are moderate with no risk factors or no comorbidities. The recommendation is that these patients should be isolated, self-isolated, and they should contact a referral line for advice on testing and referral, but they should be in touch with some doctor or healthcare facility so that they can be monitored closely enough, and they can be advised to come to a hospital in case things don't seem to be moving in the right way. Similarly, there are those patients who are moderate and have risk factors, and they obviously, some of them are critical. They obviously need to self-isolate and consult a doctor as soon as possible for hospitalization and for inpatient treatment. Now, how do you classify them as mild, moderate, or severe? I'm going to come to that in the next few slides, and we will talk about that. And it's been around for a year. I'm sure most of you know about that. The National Institute of Health have got some guidelines, and those guidelines, again, remember, guidelines is a piece of document which actually helps you to essentially uh, have a pathway or have a direction in which you can support these patients within the realms of safety. You are allowed to take a liberty to go a little bit on either side of those things, but you don't deviate from the path completely. That's what we need to look at for guidelines in that aspect. So to provide supportive care, you need to take steps to reduce the risk of transmission and advise patients on when to seek an in-person evaluation. We've already talked about that. The NIH also recommends that triage versus telehealth visit before receiving a patient in person. We've already talked about the 2 hospital studies, and we talked about that. What's important is patients who have clearly got a respiratory problem or dyspnea should be referred for an inpatient evaluation and should be followed closely during the initial days. And management plan should be based on patients' vital signs, physical examination, risk factors for progression of illness, and availability of healthcare resources. Now, this is a very, very powerful statement, the last one. We quite often are swayed away by CT scan scores. It's a very important thing to understand that we need to look at the patient and score the patient based on the severity on the clinical signs and your physical examination. And then use the availability of other healthcare resources, which may include an X-ray or CT scan, to base your management plan. it should not be vice versa, that just because the CT is 10, but the patient is absolutely fine, I'm going to still do a particular plan which will probably not be required for the patient. But if your patient's vitals are not good, but the CT scan score is still 5, severity index of 5 on 25, you may still want to do it with the patient because the vital signs are not good. So clinico-radiological dissociation is often present in these patients, and often CT scan may not present the true picture, and vice versa. Often a patient's true condition may not be basically reflected onto the CT scan as well. This is where the AIMS and ICMR protocol comes into the picture. It's a very, very simple algorithm. If you look at the algorithm on the right, and then we will come on the left with the important points, and we are going to talk mainly about outpatient category. So they have this mild, moderate, and severe, and they talk about mild patients who have got upper respiratory symptoms, maybe without fever, without essentially having a pneumonia or a lower respiratory tract infection, and no hypoxia. These patients are advised home isolation. And these patients essentially need to isolate themselves and get themselves tested. And you need to have a symptomatic management for these patients. Now, what's a symptomatic management? A symptomatic management quite often requires you need to think, and quite often requires a simplistic attitude. A simplistic attitude means you obviously ask them to be well hydrated and well nourished. That goes without any doubt. You need to think of tapering down their fever as quickly as we can, and hence antipyretics in form of paracetamol plays an imperative role in their symptomatic management. Some of them may have a cough, and an antitussive to just make them feel better would be which would be very, very good. And multivitamins. Now, multivitamins, there are roles of these multivitamins, especially zinc, vitamin C, for example. You need to bump up your vitamin D levels if they are low. All of us Indians have probably got, at least the vegetarian class has probably got a significant amount of risk of being low on vitamin B12. And all of us who work indoor have got a significant risk of being actually low on vitamin D. So need to keep that in mind and just bump up the vitamin D. Vitamin D and vitamin C have both shown to have a good adjuvant role in these patients in terms of supportive care. What is important is to monitor the vitals. So all the patients should have a pulse oximeter. Try and put the pulse oximeter in the middle finger if they can, and monitor the saturation and oxygen and temperature at least 3 times a day. I'm going to take one step ahead. One of the simple tests which I always ask my patients to do, and we actually published some data on that last year, is you need to unmask hypoxia. By the time you have hypoxia at rest, it is probably too late. So you need to unmask hypoxia. And how do you unmask hypoxia? You do a 6-minute walk test. By doing a 6-minute walk test, you start measuring the saturation at rest. Ask the patient to do a 6-minute walk within the confines of their room. And at the end of the walk, if the saturation has fallen down by more than 3% from the baseline or below 93%, that means this patient is hypoxic. And you need to get them to a hospital or start them on steroids or do both together. It depends on how the patient is. And other therapies which have been recommended are Ivermectin, once a day, 12 milligrams to be given for 3 days, or hydroxychloroquine, which I think is, there is no data for that, but still, nevertheless, it's a part of our ICMR protocol currently. And one of the new things which have come out, the STOIC trial, which was published a few weeks ago, actually talked about inhaled budesonide. Inhaled budesonide is, I think the brand name may be something, but inhaled budesonide is essentially inhaled steroid, and it is available in 200 micrograms puff, and you need to give 800 micrograms twice a day for 5 days for patients who are symptomatic and persist beyond 5 days if their symptoms are basically still there. Now, how to give this is very important. So ivermectin is straightforward. You give them once a day for 3 days. And for inhaled budesonide, because it's an oral steroid, you need to avoid oral thrush. Make sure that the patients gargle with some betadine or some salt water gargle at least 2 or 3 times a day when they're using inhaled budesonide as well, so that they do not have the local deposition of budesonide and start having oral thrush or fungal infection of the pharynx or larynx. And you need to intend this to be given through a spacer. If you can give it through a spacer, teach your patients how to use it properly so that it actually is delivered into the lungs in an effective way. That's where it's going to act. And where is this evidence coming from? Evidence is coming essentially to the point that we have avoided these patients from deteriorating and presenting to a hospital. Now, some of the important therapeutics which have come out, one of them is ivermectin. Until last year, we were not really aware of this. However, the interest snowballed after the release of two publications. One was a preprint study and an in vitro study published in June 2020 in the Antivirals. In the 2021, it basically showed a study in the infectious journal, the International Journal of Infectious Disease, beg your pardon, showed that there was a early clearance of the SARS-CoV-2 virus in patients who were treated with ivermectin, indicating that early intervention with ivermectin may actually limit viral replication within the host. That's what we want. We want to limit the viral replication as quickly as you can limit the viral replication. Probably the effects of COVID-19 virus are blunted down. And if you are able to achieve them within the first few days, most of the drugs are actually going to look at the viral replication because the clinical effects may be very difficult to actually be measured right now. Now, how does this act in terms of actual action on the patient? So we know that it is decreasing the viral replication, but it probably works by the way of promoting host immune response very, very effectively. It is a multifaceted antimicrobial, antiviral, and anti-cancer properties. Ivermectin seems to have a multifaceted role, and it also plays a key role in many essential biological processes, which and considered a potential candidate for treating the COVID-19 patients. It also has an immunomodulatory effect to the host, which is always important, and it actually helps up your immunity in modulating it in the right way. And studies have shown that it may be associated with a lower mortality rate and shorter hospital stay. However, as always, a practice-changing study may be a few days away, but at the moment, the trends are looking extremely important. More importantly, you all have these patients come and talk to you. Doctor Saab, side effect to nahi hai na. It probably has got the least side effects. So its safety profile gives it an upper hand when you compare it with the other drugs. That's the beauty of ivermectin, that you can actually use it very, very safely in all age groups. Now, another drug which has not been mentioned in many guidelines, not been talked about, but I think has got a very important role in an adjuvant therapy, as an adjuvant therapy in treatment of COVID-19 is melatonin. Now, how does melatonin act? It probably has got effect in a critically ill patient. It reduces the vessel permeability. It reduces the anxiety. It's got a mild sedative use, and it sort of improves your sleep quality. All of these are so important for a patient who is alone in the hospital high dependency unit or ICU, is looking around, only seeing faces covered with masks and face shields and bodies covered with this PPE kit, looking like astronauts walking around him. And in the white light of the hospital, they lose their sleep wake cycle. They often get up finding themselves not aware whether it's day or night. And that's where the problem is, that this melatonin seems to sort of have a good sleep quality. It has probably been beneficial for better clinical outcomes of COVID-19 patients if used at the right time. There is some data that it is useful in inhibiting cytokine storm that needs to be studied a bit more before we can actually talk about it in an effective way. And obviously, again, I think it can be given as an adjuvant with other pharmaceutical agents, which would possibly having more side effects, and we could be very, very assured that it may actually get blunted if we have the melatonin given with them. So I think this is another pharmaceutical agent which actually is looking at the mental health of the patient, is also looking at the vessel permeability. It's possibly helping you into a cytokine storm, and it may have overall better outcome for these patients. So coming to my last but not the least slide, when you have a patient, you need to essentially remember that you need to cover your mouth and nose with a mask. You need to avoid close contacts with patients who are sick. Avoid traveling to cities which have got high COVID cases currently. Do frequent hand wash. Use melatonin in a dose of 3 milligrams to maximum 10 milligrams, 60 to 30 minutes before bedtime so that you have a good sleep wake cycle. And when you are wearing a mask, you may possibly wear it in such a way that there are no leaks and have a personal protective equipment. And again, if you are basically having a melatonin, try to have it around 60 minutes before your bedtime so that your sleep wake cycle and your overall effect on the melatonin takes place quite nicely. Thank you very much. That was the end of my presentation. Dr. Agarwal, you can come back on the screen and you could tell me if there's any questions from the audience or if you have anything to be clarified. I'll be very, very happy to talk about.
First of all, thank you, sir, for that wonderful presentation. And definitely, it was having a lot of information, which I'm sure all of our doctors, I mean, who are currently, I guess, more than 1,500 doctors are there who are logged in. So definitely, it will be helpful to them. Now, so there are actually quite many questions actually. So I have to scrutinize because we cannot take each and every question. So now the first question is, can doctors, I mean, at the OPD, only mild cases or mild to moderate cases? I mean, how, I mean, although there are clear-cut definitions, I mean, what are mild cases and what are moderate cases, but still, so what is your opinion? Which type of patients our doctors who are sitting at out clinics can see, sir?
Look, I think if you have anybody who is more than moderate with comorbidity, they need hospitalization. Okay. It's very clear. It's not difficult at all. Now, let's put up the practical aspect. You are in Delhi right now. Tell me how much time it takes for a hospital bed to come up.
It's a lot of actually. I mean, they are not available at all.
1 to 2 days, right? At least maybe 1 day, maybe 2 days. I may be wrong. I'm in Mumbai, so you need to tell me. But,
no. It might be more than that also.
Yeah. So at least 1 to 2 days. So are you going to deprive your patient? See, it's sad that we have to even discuss this, Dr. Agarwal. It's sad. You know, in a normal circumstances, this should not be a point of discussion. This would be like moderate patient, boom, get admitted. Don't worry about it. We will get you a bed. But that's not the in that case, I think we may have to actually go beyond the boundaries which are set up. That doesn't mean that you take up patients who are very, very sick and just continue treating them at home. That only means that you continue treating them till they find a hospital bed. Clearly, asymptomatic and
Dr. Pandit?
At home by the doctor. Can
so
be
your screen was
hospital bed is awaited, it's fine.
Okay.
I don't know
your
why my
screen
internet
froze in between. So if you can repeat your last sentence, sir, please.
So I'm sorry. I think my internet connection is breaking up in between. Is it all right now?
Yes, sir. Yes, sir. It is all right.
Oh, I'm so sorry. That's what happened before as well. I was quite worried when suddenly I realized that I'm not hearing anything. Look, what I said is that in desperate times, you may actually treat a patient beyond what you would normally do in your OPD or at home, isolation. But that is strictly awaiting a hospital bed. Because as human beings, it is our duty as doctors to treat them to the best of our ability. We understand that the hospital bed may be a day or two away and give them whatever you can at home awaiting a hospital bed. That does not mean that you change your focus and see, यार ये तो अच्छा हो रहा है मैं इसको अभी घर पे रखूंगा. No, absolutely not, because the same patient may respond for a day or two and then worsen. If it clearly requires admission, you keep on trying for admission, but till that time you can continue treating him at home. That's how I like to put it.
Sure, sir. Thank you, sir. Sir, the next question is, although now AIMS and ICMR, they have put budesonide as inhaler in their guidelines for the mild patient, I mean, who are at home. But sir, they have clearly mentioned that it is 800 mcg dosing in with the inhaler, whether it's MDI or powdered form. So, sir, is it inhaler is only required or it can be given through nebulizer also? Is there any possibility?
So I am not aware if there is a preparation aware of which can be
like
used in
rescues are
nebulizer.
there for budesonide.
So if there are rescues available, again, nebulization problem is that nebulization actually spreads infection as well. So I would say that in general rule is that for any viral infection which is known to spread through fomites, droplets, you probably need to avoid nebulizers. So inhaled spacers are the best so that it actually is an enclosed area and you can go in. But it's important for them to be gargling the mouth after the use. Otherwise, you'll have deposits of steroid in your mouth and then you would have to promote oral fungal infections, which needs to be avoided.
Oh,
So just a
that's
little bit of
really
a
good
gargle,
point, sir. Mhm.
so that's not mentioned in any guidelines. So you need
Mhm.
to. So it's just a salt water gargle is also a lukewarm salt water gargle is fine, or if you can have those 0.5% betadine, I think it's available
Mhm.
in form of a gargle.
0.2%
You can
betadine is
just
available, sir.
yeah, you can use that as well. The betadine gargles can be used as
Yes,
well.
sir.
But
Mhm.
again, you don't have to be fancy. A salt water gargle is fine. And you
Okay.
can just save money on that.
Sure, sir. Thanks, sir. So, sir, now third question is, sir. Now nowadays, like everyone is going behind remdesivir and all, but there are certain trials like solidarity trial and all. They have shown that there is no added advantage of remdesivir. So, what is your point of view, sir, on that?
I think it's a very loaded question. It's not a very easy question to answer.
Yes, sir.
I will be very honest from a point of
Hmm.
view of a doctor and from a point of view of a scientist as well. Okay, so let's say what science we know right now. First of all, we know that remdesivir does not save life. None of the trials have actually shown any mortality benefit. Okay, the ACAT trial, which actually was the Solidarity showed that it was not saving life. The other trial also showed that it did not save life, but it reduced the hospital stay by 1 to 3 days. Okay. Now, in these times where you can send a patient home 3 days quicker, means that you can actually take in more patients in your hospital. Not because hospitals want to earn profit, but because there are patients. There are
Yeah,
so many
patient waiting.
patients there.
Hmm.
Okay, so it's the need of the hour is to actually take in as many patients as we can, so that we can be at their service, right? It has shown to be effective as an antiviral in stopping the replication of the virus. Okay, that means that it is best used when the viral replication is happening, which means that you need to use it between second to 10th day of the onset of symptoms. If you use it beyond 10 days, I think it's not going to have its own better benefit. Otherwise, you need to use it between 10 to 15 days who are going to be treated at home, because those patients are not going to be benefiting from it as well. So somebody who is moderate or somebody is progressing to moderate to severe certainly would benefit, but certainly who has a multi-organ failure and is 10 days beyond the illness, I think we should not be using it. That's from a scientist's point of view. From a doctor's point of view, if I have a patient who is within the first 10 days of illness, then the only viral agent which has shown to have some effect in reducing the hospital stay right now, only viral drug, antiviral drug, beg your pardon, and beg your pardon, is actually remdesivir. So I would probably use it within the first 10 days as a doctor and not worry about anything else. The rule of thumb, which ICMR has also pointed out, is that anybody who needs oxygen, consider remdesivir for them. Now, that's where it is. It is almost like remdesivir is searching for a disease. It's not the other way around. Remdesivir is wanting to treat some disease. We're talking so much about remdesivir, but my friend, if you are way beyond 10, 12 days, and the doctor is still prescribing you a remdesivir injection, you could start thinking in your own mind that it is probably not going to be of any use. But it's almost become as if it's a crime not to prescribe remdesivir for a hospitalized patient. That's where the whole mayhem is about.
Okay, sure. Thank you, sir. Thank you for clearing out all the doubts about this remdesivir. Now, sir, as we are already aware, there is no clear-cut treatment for this disease. Also, we have to take some preventive or prophylactic measures. So, yes, social distancing, wearing mask, and hand washing is definitely the three thumb rules which are there. But sir, from the preventive point of view, are there any medications like ivermectin showed in some study that it has some prophylactic role, and melatonin also showed that yes, it might also have some prophylactic roles, sir. So, what is your point of view on using ivermectin and melatonin as a prophylaxis or preventive therapy?
Look, I think ivermectin definitely have got a little better evidence than melatonin right now. Again, I'm talking as a
Mhm.
scientist,
Right, sir.
but the evidence is not overwhelming currently. Okay, so if you look at the evidence, it is not overwhelming, but that's all fine when you have isolated pockets of cases.
Mhm.
I can be a tight up scientist and say, boss, these are just so many cases. Nobody else needs to take ivermectin. But when you have a pandemic of this proportion, and if somebody comes in the home who is positive and the others are negative, I would probably be inclined to give them something for their own benefit. And that something would be ivermectin today. Okay, because there is no other drug which has actually shown to have any form of a prophylactic benefit. Certainly not HCQ. I think we've gone beyond hydroxychloroquine. Ivermectin certainly helps, and whether it is going to prevent it in a definite manner or not, I think that evidence is there in smaller trials, but it is certainly creeping in. And I think as time goes by, larger and larger trials would be published. We could be looking at it. So currently, the most promising prophylactic role seems to be of ivermectin. Yes, melatonin is there, but ivermectin probably seems to have a better evidence than that.
Sure. Thank you, sir. So the last question of this meeting is that about vitamin D. I mean, although sir, you already explained about why vitamin D. I mean, it is already deficient in most of our Indian population, but still the role of vitamin D3. Like there was one study published from PGI Chandigarh, I guess last year. Dr. Ashur Rastogi was there as a principal investigator of that. So it showed that high dose of 60K of vitamin D3 if given for 5 to 7 days continuously instead of weekly, it actually showed some results, some good positive responses in COVID positive patients. So what is your take on overall vitamin D3 should be given to COVID patients, or in what doses it should be given?
Look, I think so. Vitamin D is necessary as a whole immune complex. It is necessary. Okay, I know that there is a study and two which are talking about giving high dose vitamin K or even high vitamin D or even cholecalciferol 6 lakh units to be given as a single dose. But I have my doubts about the utility of that right now in mass scale. What is very clearly established is that when you supplement vitamin D along with calcium and you top up the vitamin D levels over the next 8 to 10 weeks. Now, this desperation of using it within the first 5 to 7 days is because we're dealing with the acute illness, which is not going to last for 6 weeks, but it's going to basically be a game of 6 days. So people have tried. It's certainly a safe thing to do. Okay, it's not going to harm you in any way. Vitamin D has got no toxicity to do. So if you really have a very low level to begin with, extremely low level to begin with, you could try these therapies, but it cannot be at the moment made up as a guideline to give them high dose of vitamin D for 6 days in 60,000 units for 6 days or 5 days, which will actually change the practice. So there are a lot of gray areas in there currently.
So, in your point of view, what should be the ideal dose of vitamin D if patient has to take during this COVID response?
I just give
Daily
them once a
dosing or
I just give them once a week 60,000
once a
supplemented
weekly dosing?
supplemented
Okay.
with calcium. That's it. But I know a few clinicians who are doing a daily dose of 60,000 for 5 days and then follow it up for another 4 to 6 weeks with a weekly dose.
Okay. Okay. Sure. Thank you, sir. Thank you so much for this wonderful discussion also. And I'm really guessing, I mean, definitely, I mean, there must be many doubts in minds of the physicians right now also. And because of the paucity of time, we cannot take all the questions. But definitely, sir, if allowed, we will definitely have another session where we can take all these doubts again, sir. So thank you so much, sir, for joining us here and giving this wonderful lecture about COVID management in OPD level, sir. Thank you so much, sir. Thank you.
Pleasure.